All right. Hello again, and welcome to another Down Fracture podcast, a podcast for talking jaws. As always, this is Dr. Michael Wasson from Arizona Jaw Surgery, joined by Dr. Sam Bobek of Seattle Jaw Surgery. Sam, how's it going?
Good, Mike. What's happening with you?
Not a whole lot. Just here to chat with you today.
Well, great. We were brainstorming for hours over the weekend on the topic. I think we came up on bad splits.
We did. We
I like
did.
this topic.
You want to start us off on this one in a second? I guess other general housekeeping would be downfracturepodcast at gmail.com. We did get some more emails that were helpful, gave us some insight into other people's experience, had some questions about the physician assistant stuff. So good stuff. Feel free, continue to email as much as you can. And then otherwise, I would say other people maybe not don't know this, but we do have a YouTube channel and there is video on Spotify. So if you actually want to see some of the things we're referencing, we don't always have images and usually they're borderline garbage. But if you do want to see those things, there is video available.
Yeah, I think
Um,
today we actually have some pictures of stuff. I mean, I think because bad splits are hard to describe completely. I think it's easier when you got at least something to
Absolutely.
wiggle or cursor around on.
Yeah, because they have all these like classification systems and stuff, which I have mostly found useless.
Yeah, totally. I think looking at these different crack patterns in a ramus and angle. And it's just, I think most people, and for me at least, it's easier just referencing it as the common ones like buccal plate, lingual plate, condyle, cornoid buccal plate, those sort of things, right?
Right.
Um, yeah, but I think it's a good topic because it's like one that people don't really like to talk about, even though it's basically what stresses everybody out when it comes to sagittal osteotomy. Um, and it's the thing that you can't really learn unless you do it, right? Like you can kind of learn, so you have some management strategies going into surgery. But you remember learning sagittal osteotomies and how much it was feel oriented.
Oh yeah, absolutely.
And
And you
one of the
just don't
feels
have
is
that. You
when
don't
it's
have
going
that.
the wrong way.
Yeah.
Um, so I don't know. I think for me at least, bad splits are like something I was always freaked out about until you just live the life of having bad splits. I actually remember in fellowship, we didn't have a single bad split, which was crazy. Um, and then you get into real life and it was seemed like a fairly regular event. And so learning how to manage those is, I think, part of the reason we want to talk about these things and just kind of take away some of the maybe fear behind bad splits. Do you remember your first bad split, Mike?
I do vividly because it was one we were just kind of talking about when we were looking at images in our 5 minute prep meeting here.
Did you know
Um,
it was happening, or did it
no,
just happen?
no, you just that's what I will always remember is I didn't figure it out. And that would be some of the things I would advise to the younger surgeons is, yes, so much of this is by feel, but also like when you just feel maybe doesn't encompass it completely, but just whenever you get a sense that things are not going right, like, hey, I've gone through all my cuts. I'm getting some separation with the osteotome, but this thing still doesn't want to split. Like something, when you feel like something's going wrong, you should probably pause until you figure out what's going wrong. Instead of just like, oh, well, I'll just press harder on the spreader and the osteotome until something splits, kind of thing.
Yeah, I mean, when it comes to my experience with bad splits, it was I had some in residency, and there was I think we had a common faculty person who, I mean, basically it was a exploration of bad splits, like, something the mandibles in different pieces, and then you got to kind of figure out how to put it back together. Um, and when I got out, the buckles, the same stuff that you learn, it's very true, right? Like if you don't cut the inferior border well, then the buckle segment's probably going to break off.
Mhm.
Trying to see if the superior border expands evenly can help you out with that. I think as time goes on, I've appreciated that when I use an osteotome at the inferior border, at the bottom part of the dalpont, If it chips, that means it's not cut well. I don't, you probably already knew that, but for me, it took a while to figure out that cue, like chipping of the cortical bone. You know what I mean?
I know what you mean, and it did not take me long because I think you told me that years ago.
Well, because it's just I don't know why I thought that I just needed to overcome the chipping with more osteotoming, and so kind of if you recognize that at the inferior border when you use your osteotome, it's probably not cut all the way. Wisdom teeth play a role here. Age, mandibular anatomy plays a role. Revision, those sort of things play a role. So, what are you doing with
Absolutely.
wisdom teeth?
What's that?
What are you doing with wisdom teeth? You taking them out now or
Yeah, we
impacted
talked about
wisdom
that
teeth?
as one of our first episodes, and I think we frequently convince each other to try new things, and I think I'm coming around to your philosophy of maybe trying to take as many of them out when it makes sense at the time of surgery. Um, Although it does maybe make the split a little bit more difficult, I think from a practical standpoint and patient standpoint, it makes a lot more sense.
Yeah, I mean, I think for people who maybe not have heard that whole discussion, it's the idea of taking impacted wisdom teeth out ahead of time or at the time of surgery. Erupted teeth, I keep in. I assume you keep in as well.
Yeah.
But impacted teeth, the idea is getting the wisdom tooth out will help reduce the rate of bad split. I think the data out of Canada clearly showed that wasn't the case. It just changed the type of bad split you had. Um, but technically speaking, using a reciprocating saw or for you, piezotome, the wisdom tooth's in the way, right? And so it can kind of slow the case down and definitely right where that tooth is at the ramus um, can be a bit of a weak point for weakening the buccal segment fracture. So,
You said buccal segment or lingual? Do you mean lingual segment?
well, yeah. So classically, with the having a tooth in there, you have more lingual plate fractures, right?
Yeah.
But I think like your what is that diagram that you have up with the A and B, the A
Yeah.
that shows kind of a normal buccal segment fracture.
Yep.
If you cut or if I cut the like the horizontal limb of the sagittal split osteotomy, and let's say it cheats a little bit laterally because I'm trying to miss the wisdom tooth.
Hmm.
The wisdom tooth's big and it's a short angle, let's say class 3 or something, then that can be a weak point for sure.
So
And
you're saying like you're thinning out the buccal plate and you're more likely to fracture. Is that what you're getting at?
yeah,
Yeah.
totally.
Okay.
Here, let me I'll show
You want
you
me to share your screen?
yes. I don't because I have let's see if I can actually make it a slideshow. This doesn't show the wisdom tooth, but imagine impacted wisdom tooth on this case.
Oh,
Do you am I showing it now?
I can see your image in your cursor. Yeah. Is that what you
Yeah,
mean?
okay. This is just class 3. And this was a situation a number of years ago, where I don't know if you can make it out, but there's like a crack in the buccal segment, like we're looking at. I'll see if I can draw
Yeah,
it
I
on
could
here.
see it.
Like this
Yeah.
thing.
Yep.
And, it wasn't clearly evident. It was one of those that I was hoping it was going to be okay, but it obviously wasn't here. Because the crack of the weakening led to loss of fixation, which was ultimately non-union that had to be repaired. But during surgery, especially with wisdom teeth, it can really weaken that little buccal segment. So depending on your fixation strategy, this is a plate that can cause you some troubles. So
What is that plate?
I know it's a dog bone with striker. It's gonna make me feel old how old that case is. It's at least 10 years old. Um,
I just
uh,
want you to know I'm judging you right now.
I'm feeling judged. I feel it. And so, when it comes to buckle plate segments or let me see, bad splits in general, when you have a buckle plate fracture, it's very much like, well, shit, now what am I going to do? Like, what's next? Because you got to split the mandible, right?
Right. Or, I
So
mean, if it's the first side or first jaw, I mean, you can always abandon it and come back another time after you fixate the buccal segment, but I don't know that that's a practical way to do it unless you just feel like you can't complete the split for whatever reason.
I think from a patient management standpoint, it's best to try to carry out the split if at
Yeah,
all
no doubt.
possible. I think from a like what at least I learned when it came to if you break a buccal segment off, and so that you still have the angle in, you turn an osteotome in medially underneath and behind the nerve. So like this image is showing, to turn the osteotome in. The key thing on these, for people watching, this just shows a or not watching a turned in osteotome, like a curved osteotome, pointing medially inside of a sagittal split. And so if the buccal segment breaks off, you still have to complete the split so that the condyle stays proximally in the distal segment distally. The problem here is dull osteotomes. Do you encounter those in real life?
Of course. I think we all do, right? That's a problem.
It is because these are the ones that start getting hard, I think. When it comes to the problem with those is that they can start skiving laterally and you don't really recognize it. For me, I have a visualization of one of those. You're asking me what's going on with this image, and I don't know if you can see this thing. It shows the condyle, coronoid process, and buccal segment, but it has the angle and the kind of separate, but the angle was staying in the distal segment. And so if uh, the osteotome skives, it's I think key to focus on cortical bone or not. And so if you're seeing cortical bone through the split, you're probably too lateral.
Yeah.
Um, I don't know. I find that one hard to manage because that's kind of like the bad one that starts moving up towards the condyle and can lead to, your inability to split the mandible or splitting the mandible and you can't fixate. So I
That's
think
a bad day.
preparation helps with it, but it is a bad day. I think any senior surgeon or anyone that does a bunch of this has stories of bad splits. And when there's something that comes up like a buccal plate fragment that breaks off, you don't want to keep making things worse. What's your technique to turn a split in when you get a buccal segment fracture?
Yeah,
Pre-cut?
it's I've been fortunate. I haven't had, well, we've I guess one thing we should probably discuss is to answer your question better is what are we constituting as a bad split? Because there are people in the literature, as you and I know, that basically say a bad split is anything that deviates from your intended split versus people who say anything that means I couldn't get fixation or had to alter my fixation. What are we just terming a bad split here in our context?
I feel like most people use the definition of a split that went in a different direction than you intended.
Yeah. So I mean,
I mean,
like some people would even say like a lingual plate fracture. Like I don't consider that a bad split because I'm going to use plate fixation and it didn't vary my procedure much at all. And they would say, no, that's not a bad split. But you're saying you don't want to judge it in those terms,
well, because I mean, the term bad or, good, I don't know if I like that too much, but
right?
in terms of how and I'm by no means the the holder of truth on this, but in my mind, bad split is just one that goes a different direction than you had intended. And so, because you'll intentionally break lingual plates for asymmetry cases, or if you're doing a widening case or something. I've intentionally had a buccal segment fracture on a revision case, just to manage the inferior border. There's times where you intentionally do things, and even if it's outside of like your traditional sagittal split osteotomy, it's not necessarily a bad split, right?
Right.
So I think of the bad splits, buccal segment, that's the one that turning it in so you don't get the condyle to break off, and then fixating. Would you learn how to fixate the sagittal or the buccal plates fracture? How do you manage
It
that?
kind of depends. So I've had some people who I think typically what I see most is trying to put a positional screw through it eventually. But
Yeah.
I've seen plates to try to just put it back into position as well. I don't know. I've been fortunate, and I know whenever you start talking about complications, when you say you don't have a lot of these, it kind of seems like you're being a jerk or not honest. But I haven't had a lot of them. Most of mine have been the lingual plate, and it doesn't often change how I'm going to do things. And then I've had two or three. similar to what you were describing a second ago, which I think is as we were talking beforehand, is the worst, or at least the most difficult to deal with. And that's the one where it's propagating up to the condyle, but it appears as if you've done this, like you've completed the split at the inferior border. It's happened so low that you're seeing your proximal segment separate, and it looks very close to like a normal split anteriorly, but it's propagating up and maybe going up the condyle. I've had that happen to me two or three times, and the first time I did not recognize it. And I could tell when I split it, I was like, something's off here, but I couldn't really figure out what was going on in real time. And that was one of the only times I've ever wired a patient shut intraoperatively after an orthognathic case because things were just not going as I thought. And the only reason, I feel like the only other reason, the two to three other times that that split's happened to me, the only reason I've recognized him is because that first one happened to me. Like, had I not lived that the first time, I don't know that I would have recognized it the second time and then tried to correct it.
Yeah, breaking off condyles, it's like I remember thinking that's like a ridiculous thing and how could that actually happen? But that was more me speaking from inexperience, right? Like
Yeah.
because from the image that I have up, does my tell me if my writing,
Yeah,
but
I can see it.
you're following along the inferior border through your split, like you're visualizing it this way,
Hmm.
and it just starts drifting lateral, and you don't
Exactly.
really know it, and so it drifts up here,
Yep.
and you try turning it in with your osteotome, because you don't really know that you're lateral to the angle here, and if you don't turn this in, then the condyle will be in your distal segment, and you'll
Yep.
just have the cornoid process and buccal plate as one piece. But often there's like a weak point here, right? Like, if this keeps going, you may not recognize to here, then it's getting really thin, and then it can break here, and then you have cornoid process,
Yep.
buccal plate, condyle, you know what I mean?
Yep.
And depending on how that goes, that's a tough, that's a tough
Which
split.
it's just kind of tough to recognize because it looks like it's separating. You know,
Yeah.
you're looking at it and it's like, okay, this is splitting, but at the same time, that's what I was kind of getting at the beginning. When I look back on it, it's like, okay, this isn't splitting. Like I'm doing the spreader and I'm doing this at the inferior border, and it's not splitting. Like
Yeah. So,
you go back
it-
over all your osteotomies, like you're trained to do,
yeah.
and you still sometimes it's still going on, and it's just kind of. So you're like, well, am I just not putting enough pressure on it? And you kind of eventually put enough pressure and something happens. And then if you hadn't redirected it, then it's the bad thing.
Yeah. I mean, um, I don't know. Now I take breaks in these. I know I made reference to that last time, but if I'm starting to get confused and I feel like, I'm suspicious of the split going more towards the condyle than I like, there's nothing wrong with going to the other side, splitting that, getting it out of the way, and then coming back and finishing up the right. Um, Completing the split is kind of an important thing. This image shows kind of the extreme of a bad inferior border cut, not bad, but inadequate inferior border cut, right?
Hmm.
And you think, gosh, how could you do that? It's because you're visualizing it from inside the mouth, right? And you feel like you have a cut, but you're already too lateral. Luckily, this thing's still connected medially, so that the condyle stayed in the cornoid process. But there's times where that doesn't happen, right? Like this image that kind of shows the condyle as a separate segment from the cornoid process and the buccal segment. And so these are kind of what you're trying to avoid when it comes to uh, bad splits, because this is a hard thing to fix intraoperatively.
Yeah, go back to the one right before that. No, the one, yeah, is that it? Yeah, because that really, as long as you don't have interference between the angle area and your buccal segment there, you can fixate that and you're fine.
Yeah, I mean, this isn't that big of a deal. I mean, what you're talking about is in this
Yeah.
segment, because
If
assuming
you're,
that the everything's going forward, given the Dal Pont,
yep.
there's going to be interference here, which will kind of cause this whole thing to flare out laterally. So the interferences will be different than what you would typically expect.
But if you manage those, in theory, that's I mean, that's a functional osteotomy.
Definitely. And I mean, there's times where you try to perform this to alter the angle anatomy, right? Have you seen that variant of a sagittal
I
osteotomy?
have, yeah.
To purposely do this so that in an asymmetry case you move the angle down. This is a hard thing. I find this hard to carry out
Yeah, I was gonna
technically
say I
both
don't do it,
ways.
but I've seen it. I don't know what that
But I mean, in this situation, you can still finish the case and do the maxilla. So I think it's just my general experience has been if it's not quite splitting and you're spending a little bit more time on it than you'd like to be spending, um, going to the other side, chalking a a win on the other side, and then coming back and finishing up the right is a good way to go. I feel like it's just super common that bad splits seem to be more on the right side than the left.
is.
I don't know. Do you think that?
The I only have a few that are memorable to me because of how bad they were, and they were, to my memory, the three that I can recall were all on the right side.
Like, look at this one. This is a lingual plate fracture that includes a second molar. That's
Oh,
a tough one. It's actually not impossible, but I mean, right side, it's just and I don't have all examples of that, but generally most of the examples are that because you learn from the right side before you go to the left. So from a um, each person's anatomy, how the inferior border goes, how the split goes, you get some information that helps you out on the left side. And like you hear like Myron talk and he says all the bad splits happen on the left because that's the resident side. I think once you start operating on your own, it's for me at least, it seems to be a
well,
different
that's
scenario.
that's also kind of a shady approach, unless the resident's left-handed. Why do you give the resident the harder side, like intentionally? Like, wouldn't you
Well,
do the
because
opposite?
that's the easier side, isn't it? Because you learn something from the right.
Well, I mean, but it's still harder to cut, I think, if you're starting out, don't you?
Yeah, it's definitely your hands don't work in the same way as your attending's hands do because you got to come at it a different direction.
Yeah.
But yeah, buckle segment, lingual. Do you fixate the lingual segment when
I
you have it?
don't. I really don't. Do you?
Yeah. I mean, I because that's another one you like learn about is something you need to do, but I'm not quite clear why that's the case.
I mean, it's how's it different than, intentionally fracturing the lingual plate, as people do in asymmetry cases. I mean, I guess some people do probably fixate that, but a
Yeah, I
lot of
mean,
times you're just doing that and then plate fixation.
yeah, because the main thing with lingual plate fracture is if you only do positional screw fixation, then you got to figure out plate fixation, right?
Hmm.
So the fixation part, the one that we were describing is probably the hardest one to fixate when the condyle breaks off. But everyone else, as long as you can do positional screws and plates, you're fine. Um, so I mean, in in the life of doing bad splits, I think there's kind of a high frequency of those as you're figuring out surgery and getting a feel to it. But they still happen.
Oh
And
yeah.
learning how to manage them and just kind of accepting it, talking about it with others is a good approach, I think.
Well, that and just, as we often talk about, there's a time to go fast and there's a time to go slow. And, splitting is a time to go slow and absolutely take your time and watch the split. I mean,
Yeah,
I think that's one thing when I work with residents, I try to really hammer home because I think it's been useful to me is like, I want you, when I'm splitting, I want you suctioning all along the osteotomy line because I want to see all of it at the same time. And you as the assistant, maybe that was a question for you and Andrea because she's probably learned to do that for you, right? She just suctions all along there. You put the little tiny suction tip in there to help you, don't you?
I do like I do my own suctioning there. It's great.
It makes a lot of sense if you have a little tiny Fraser tip to put in there.
Yeah, like a little seven or something. Because following to see that the inferior border is going medially and not straight, and then that you're beneath the nerve, those are really the two things I'm looking for. And then kind of following it along. Um, I have a lingual plate one for you.
Let's see it.
Um, this is an MMA case. This is back when I was planning with companies, and you can see all the interference associated with it. And this would be a situation where you'd purposely split the lingual
Hmm.
plate. Uh,
Right.
in this case, though, he's kind of getting a big advancement. And on the see how the ceph looks pretty good. This is before and after.
Mhm.
Let me see if I add some three-dimensional part to it. Um, so this is 3D world. You see how thin his proximal
Yeah.
segment is in terms of things? And the plate, the amount of advancement was much bigger than the surgery plan would suggest, given that the condyles weren't seated. And so this gap was something like 17 millimeters or something like that. And so the positional screws that held the lingual plate in um, wasn't obviously going to hold the mandible together. And you can kind of see how this hardware doesn't look the best in three dimensions. You
Yeah.
probably
Looks
know
like
where
it's,
this is going, right?
yeah.
So in his scenario, it was like a 16, 14, 7, like pretty good advancement. I now have plates that are long enough for this, but the problem with this is very much you're dependent on these plates that in this scenario ultimately give up and, open bite ensues
So
and,
you're
you
what
need
you're
to
talking
fix it.
about again, as listeners maybe can't see this, is hardware failure from inadequate fixation from a large advancement with MMA.
The
You
lingual
were what's that?
Yeah, and a lingual plate fracture. So
Yeah,
MMA, if you break off a lingual plate, which is nice because it's to get rid of interferences, the trouble is you're totally dependent
on
on
your plate.
fixation.
Yeah.
And in this scenario, the plate was inadequate to kind of
So
hold the
did
mandible.
that thought intraoperatively, did that thought cross your mind
Yep.
that that plate would be inadequate
Well, because it was what I had at the time. So it was the tools that I had at surgery. In terms of putting a big recon plate in, it's
or
ultimately what I
two
did,
plates?
but
I
that
mean,
would have been the
did you consider two plates
I was and this was also a while ago. It was at a time where the biggest gap was, I think, 14 millimeters. Um, I don't know. What's your like? Because KLS has some that are ridiculous now. They're like 17. I think there's a 22. There's a 26, I believe, actually. That's
No.
millimeters in the Dalpont plate for mandibular advancement. Stryker has it up to 17 now, I think.
Hmm.
So, um, so I mean, if you're at like 16 millimeter plan, it's pretty easy to get a little bit more than that. So, might be a time for an inverted L or some different fixation to get ready. So,
Yeah,
and I
that's
think
actually where
ultimately,
I was gonna kind of direct you to next. As you know, the bad split talk generally involves sagittal splits, but do you have experience with splitting other osteotomies in the mandible that go incorrectly?
um, so you mean like ramus osteotomies and
Yeah.
whatnot?
Like if you were trying to do an L or a IVRO, anything, ever have any problems with those? Because I
I
can't
don't
speak
do
to
enough
that ever being an
IVROs
issue
really say, and L's that I do some, but I don't have as much experience as other people. L's the main thing is the two limbs, right? So that you weaken the condylar segment. So as you do the horizontal and the vertical limb that you overcut and you cut off the condyle. I think generally like that last case that I was showing you, given the amount of advancement and the interferences, um, you know, hindsight's always 2020, right? I got an old man saying it.
There you
That's
go.
yes. And so trying to learn something from bad splits and trying to prevent them or lessen them happening in the future, there are some things you can do to kind of set yourself up for success. And the planning part of it and coming up with some different plans than you typically would can be a helpful thing. So in the case of a giant advancement, the Dalpont, not giant, but generous,
That's
maybe
pretty big.
altering your osteotomy location is a good thought.
Yeah, I think that's a good. I mean, the other idea I'll throw out there while it's on my mind is, and we've talked about this before too, but I was trained almost entirely with using a drill and not a saw
For
or a
the
burr. A
cutting of
burr.
the mandible.
Yeah, a
Yeah.
burr and not a saw. I feel like, and as time goes on, you experience other things come into play here, but I feel like I get a lot less bad splits using the saw than I did with the burr. And I know the literature doesn't necessarily support that being much different. But I will notice, and I'd be interested with all the people who email us and call us every week after the show, if anyone else has similar experience having used both in the past or not. But I feel like with the saw, one of the main benefits is you have a lot more thicker, like the bone is thicker and it's not like spongy and flex. It's not as, I don't feel like it flexes as much when I use a burr and I have a wider osteotomy gap there. The downside is sometimes getting that spreader in there is a little bit challenging until you initially get something in there to help hold it open. But I feel like it's, especially on the lingual plate, when you've used a burr and you've removed a lot of that bone and you start spreading, I feel like things flex a little bit more when I've used a burr. And so I feel like as I've transitioned to the saw, I feel like I have a little bit less incidence of bad split. Now, again, I'm also older, wiser, better looking and than I was when I was using the burr. And so that could be as much of
Argue
it.
on
What
the
do you
better
think?
looking. I mean, I'm glad you have the positive self-talk. That's good.
Well, this I'm just going by what Andrea told me.
Yeah, I think when it comes to the saw, I do think it's nicer just because you have more bone stock in terms of
Right.
pushing up against things. Um, I think what I'm generally coming around to in terms of bad splits is there's some ways to set yourself up for success in mandibular splitting. And if I was giving myself advice as a younger surgeon, I would probably tell myself to watch out for older people, impacted teeth in older people. Revision cases are going to be tough.
Mhm.
Getting things set up ahead of time is important, and kind of
What do
like
you
what
mean by that? What do you mean by setting up ahead of time, getting set up ahead of time?
you're. So I think osteotomes being sharp is kind of an important one. I think that's key. Having a strategy for suction and assistance, you know what I mean? So if you're doing cases on your own, it can be a little bit hard to see in there. And if everything's going fine, it's a hard case. But if things aren't going in the right direction, it's even harder, right? And
Right.
so I think getting the personnel and the equipment that you need is kind of it's worth the time at the beginning of the case to make sure that's all there, right?
Yep.
Um, but I mean, because old kind of brittle bone will just break and it'll just go in a direction where the wisdom impacted wisdom tooth discussion has some nuance to it, and I think that if it's an older person, I would entertain taking that tooth out ahead of time, especially if you're early in your career. Because if like if you're in the middle of it, I think it's a lot easier if there isn't a tooth there.
Oh, no doubt. Well, I mean, that was the whole purpose of our discussion is it's easier to if there's no tooth there.
Yeah.
Like I think everyone would agree on that. The question is more along the lines like how much easier is it worth it to the patient to go under two operation? What's better for nerve?
Yeah, I mean, because generally you're not going to get bad splits at a high rate anyway. It's just short angle anatomy, older, more brittle bone, maybe lips that don't stretch very much. Have we talked about lip stretchiness yet or no? Probably not.
I mean, you and I have talked about it. I don't know if we've talked about it on here.
Lip stretchiness, little oral apertures that don't allow to do surgery in the back of their mouth makes it tough to access back there. But I think those kind of situations just I don't know. For me, I try to remember that bad splits can still happen and setting yourself up to make it
Yeah.
easy might be helpful there.
Another thing I've been playing around with since I've in the past few years kind of used the saw more and more is I don't know that I do this greatly, but like, well, I guess you can't see my screen, can you?
Share it.
Let me share it. So with the, can you see it now?
Yep.
Let me see what's the best image to show this in. No, probably this is the best I got. So for your horizontal cut, your osteotomy above the lingula with a saw or with a burr, you essentially are just cutting a straight line through the cortex there. And when I've used the saw over the time that I've used it, I tend to, I think that's the general thing is you can take the saw kind of at an angle and also start directing it inferiorly. Do you know what I'm talking about?
Yeah, totally.
Yeah, so like a straight with a burr, you basically have to make a straight cut, like almost just straight across. I mean, I guess you could go back through it and try to angle it down, but with the saw, you can angle it down, and then when you slide anterior to the lingula, like I tend to bury it behind there, hit my Selden or whatnot, and then I bring it a little bit anterior, and then I start kind of burying it again. You know what I'm saying? Am I
Uh,
explaining that clear?
you mean just cutting through the outer cortex though, right?
No, I mean that's kind of my point is like instead of just taking it through the outer cortex, I find that I can kind of go anterior to the lingula and bury it even a little bit as I start kind of making my sagittal cut. Instead of just going through cortex, I take it a little bit deeper, I guess is what I'm saying.
Yeah, because you just got to watch out for the real concave ramus there.
Yeah.
The ones that are super thin that when you cut through one cortex, you're lateral already, you know?
But usually you can kind of see that, or you've
Being
seen it.
in the pre-op workup.
Yeah, yeah, yeah.
Yeah, for sure. It's just, it's like you're probably looking at other things and you just assuming you've done a couple hundred of these and so you won't run into that trouble. But
Well, you
definitely
can,
like the condylar hyperplasia person, so on the unaffected condyle side, especially like hemimandibular hyperplasia, that other side is concave. Like here you go. Let me show you. This isn't, yeah, I guess this is a pretty good one. Here.
I gotta stop sharing.
Yeah,
There you go.
we're showing a lot of images today. I feel like our just listeners aren't going to be loving it, but
They're
you,
gonna
you
love
see
it.
like this, like that concavity,
Yeah.
like this is the one, right? So like if you're describing you're cutting with the tip of the saw, it's pretty easy to get on the other side. And you can kind of see like on this left side how a cut was actually made through the ramus there, and on the right the coronoid process just broke off. And this was a situation where the coronoid and the buccal segment broke off, and it was decision was made to just close up and let it heal and come back another day. That's where I jumped in, but it's
I
it's
guess
a
what I'm
these are
getting
tough.
at.
Like look at this, look at that.
Oh,
It's
that's
thin.
that's a nightmare.
Yeah, so I mean,
There, I would
it's a
not do it.
it's a good argument to cut low, right? So don't be above the lingula. So
Yeah.
just make a cut beneath the nerve. Obviously, you have to be careful, but in that scenario, if it gets super thin there, um, it's not unreasonable to cut beneath the nerve.
Well, I mean, I think if you cut beneath the nerve, it solves every problem, doesn't it? That's what
Um,
we all should be realistically doing.
all. Well, I know it's
I'm
good
just
for
trying
some
to get you
things. I think
fired
it's
up.
it's
I,
tough. Yeah, I think
I
it's
know there are certain topics that will get you a little riled up, and thought that might have been one of them.
no, I don't hate the idea. It's just I'm partial to freeing up the nerve, I think. But I think from the standpoint of the real concave ramus, you just gotta be careful with what you're describing with the saw.
No doubt. And then I guess the take home point, I guess, that I'm getting at is with the saw, I feel like you have the versatility to kind of bury it a little bit when applicable. And I feel like
Yeah.
that helps a little bit. Of course, you got to know where your nerve is, what direction it's going,
Yeah, and I
whether
think that
the ramus anatomy.
the nerve stuff is the other part I guess we haven't really talked much about in terms of like the reasoning why bad splits happen because it is a little bit hard to cut through it the canal without cutting the nerve. And there are anatomies where the canal it's basically just cortical bone and canal, right? And might be a time for piezo. I know you don't like those things, but it's not a terrible time for those. Um, and it's really easy to cut superficially and then accidentally have a buccal segment fracture or something like that. So I mean, if it's not the inferior border, it's probably at the where the canal is that it's not
Yeah.
quite cut deep enough. So
So what are your take home points here? You kind of said the advice that you would give to your younger self. You want to wrap it up, or do you got anything else you want to talk about?
I don't have too much else. I mean, I feel like we kind of beat the bad split topic to death somewhat. I mean, I feel like wait, is
No,
this
that doesn't
no.
count. You
Okay.
could say beat a dead horse. Is that what you're looking for?
Maybe I don't know. I don't know if I like that one because it just seems mean.
Have
I mean,
you ever
horse
seen a
is already
horse?
dead.
Have you
Yeah,
ever
I think
seen a horse in person?
for sure. I live in a neighborhood where there's some horses.
Oh yeah, that's true.
So I think anyway, I got sidetracked on that visualization. But no, I mean like the advice for my younger self, it's really, I think, getting instruments ahead of time, watching out for the anatomy where you're going to be at higher risk, and really getting outside of the viewpoint that I always do things one way. Like I only put positional screws, I only use plates, or
Yep.
I only use a saw, or I only use a burr. Because I mean, there's times where you need these other techniques to help yourself out. And so,
Yeah, that was going to be mine. I was going to say, what I would tell my younger self is, honestly, and this is up for debate. I don't want to sound like this is for sure, but I would tell my younger self to transition to the saw sooner because I was trained just with a burr. Or if you have the opportunity in residency, if you use one or the other, see if you can try the other. maybe my experience is the opposite for you, and you would like the burr better. But get experience doing both.
Yeah, I
And
mean,
then, there are programs where you only use one version of the fixation. I would say that's the other thing of can we try doing the other version of fixation? If you have the opportunity to learn from someone else, do that.
yeah, I think that I was lucky that I saw like Lindemann burr
Yeah. That's what
and
we almost always used.
Fisher burr kind of cutting everything and then saw and then anyway, it's good to see the different ways. And ideally you see enough bad splits in residency, you get some experience. But honestly, it happens at a low enough rate that it's just hard to get to
It,
the numbers of managing 5 buccal segment fractures, or you know what I mean? Like it's everyone's got a handful of these things. So when it comes up in training or if it comes up in real life, then talking about it with your jaw surgery buddies is good because everyone can learn from it.
yeah,
Like
no
we
doubt. I mean, I think,
so
I would echo your kind of sentiment of you didn't see any bad splits during fellowship, which is remarkable as with that level of volume. But like, I don't remember seeing many of them in residency either. Like we were mostly working from, I had the good or bad fortune of it. In this context, you'd almost say in some ways it's bad because you miss out on that experience. But the people I worked with had been doing hundreds of cases a year for decades, and so like your incidence of these things is low. And most of the time, it was like a lingual plate, and it's like not a big deal, and you don't even really recognize it as a problem, and you miss out on that experience some. So if you're a resident out there, what I would encourage you to do is create some bad splits so
don't
that you can.
purposefully doing that would be a bad game plan. I mean, conceptually it'd be nice. And I think looking at mandible anatomy critically in the workup and another plug for, doing in-house planning, is you can kind of see anatomy that, yeah, I could see how a bad split could happen here. I could see that. And maybe we use something different. I feel like there's learning there and it's just, I think it's great to present cases that go, in a direction you don't want them to go because everyone's going to learn from that. So if anyone listening had any tips or wants to show us some stuff so we can learn, I'd love that. So,
Yeah.
because when it comes to this stuff, it's acting like you don't get bad splits and, like it's a terrible thing that you shouldn't have happen. I don't think that's true at all. So,
Yeah.
anyway, I like this topic. So,
All
um,
right. Well, we'll wrap it up from there. So I guess that was another Down Fractured podcast, a podcast for talking jaws. As always, email us downfracturedpodcast@gmail.com. Cases, your experience, topics that you would maybe want to hear. We've gotten some feedback on those, and most of the things that we've gotten requested are on our list that we just haven't gotten around to. Maybe we should get around to them sooner since people are requesting them. But
yeah, no, I think we will. I think we have a couple guests next few weeks. So
yep.
that'll be good
All
to
right.
hear from them.
Well, see you guys next time. Have a good
All
one.
right, man. See ya.